Game.
So what we have initially is acute bilirubin encephalopathy, as it was found in the MRI that patient had a hyperintensity in the globus pallidus. So what is acute bilirubin encephalopathy? It is actually bilirubin toxicity to the basal ganglia and various brainstem nuclei, and that includes the globus pallidus, as was the case of the patient. Acute bilirubin encephalopathy is an important cause of cerebral palsy, developmental delay, and hearing impairment. Acute bilirubin neurological symptoms manifesting in the first few weeks of life, as was manifested in our patient. So what is the pathophysiology of such condition? Again, that already told you about how bilirubin is broken down or metabolized in the body. However, in cases when there is problem in the metabolism of bilirubin, such as in cases of hemolysis, increased hemolysis in the body, or liver disease, which includes diseases such as hemolytic disease of the newborn, may be due to ABO or blood type incompatibility, G6PD, Crigler-Najjar or Gilbert syndrome, and other diseases of the liver. In this case, there is an increase in unconjugated bilirubin levels, especially if we are considering a possible hemolytic or a pre-hepatic case or cause of hyperbilirubinemia, which usually occurs if there is acute hyperbilirubin or acute bilirubin encephalopathy. So the unconjugated bilirubin levels, if there is an increase of more than 5 milligram per deciliter of total serum bilirubin, this then deposits on the skin, sclera, and mucous membranes. However, if unconjugated bilirubin exceeds 25 milligrams per deciliter, it now deposits in the brain, particularly in the basal ganglia. As to why it specifically deposits in the basal ganglia, there are a lot of theories about it, but there's no study proving why it stays on the basal ganglia on that specific part of the brain. However, unconjugated bilirubin is likely to deposit on the brain and would now lead on to Kernicterus, because again, unconjugated bilirubin is hydrophobic, or it's it's not easily excreted in the urine, and it can pass through the blood brain barrier. So it is able to cross that membrane, hence being able to deposit. It is now made it's now deposited in the brain, or particularly in the basal ganglia. So manifestations, early onset, it include being sleepy but arousable, but arouses mild to moderate hypotonia with a high-pitched cry. On the intermediate manifestation, patient would present with fever, lethargy with a poor suck. Notably, our patient presented with poor suck, with irritable and jittery and strong suck, or they can be irritable and jittery with a strong suck. Cry can be a shrill. Infant is difficult to console, with mild to moderate hypotonia, with beginning backward arcing of the neck, or what we call retrocollis, opistotonus with stimulation. On the advanced, patient may present already with apnea, inability to feed, fever, seizures, semi-comatose to coma, with hypertonicity, persistent retrocollis, and opistotonus, with bicycling twitching of the hands and feet. Cry is also inconsolable and may be weak or absent. On the worst case scenario, it can cause respiratory failure or intractable seizures and eventually death. So again, there's backward arcing of the neck, petrocollis, and trunk opistotonus. So why is this so? Again, when there is problem with the basal ganglia, which is part of the brain that coordinates our movement, hence manifestations of such problems in the basal ganglia would manifest more of movement-wise. In this case, it's opistotonus, or the backward arcing of the neck, and that becomes persistent or hypertonic is in the case of our patient. So again, this time around, or this current admission here at St. Luke's, here is the most recent physical examination. Current anthropometrics with stable vital signs with Z-scores less than 2. Physical examination, the most important or the most notable is that there are no retractions, but there is noted stridor. Neuro-PE revealed awake, irritable infant with incessant crying, tendency to be in apostolic positioning with both hands and feet extended, and the feet or the legs with tendency to be scissoring, increase in tone, so that's hypertonia in both upper and lower extremities, and hyperreflexia on all extremities. Such neuro findings at this age, when patient is already at 5 months on admission, would lead to a more chronic presentation, and that is now what we call Kernicterus. So again, Kernicterus, the long-term sequelae of acute bilirubin encephalopathy, is actually a chronic and permanent neurologic sequelae of the bilirubin-induced neurologic dysfunction. Kernicterus is also called chronic bilirubin encephalopathy and is a pathoanatomic finding of intense yellow coloring of the basal ganglia, superimposed on paler yellow background as first termed by Orth and Schmorl. It presents with common complication of hyperbilirubinemia associated with Rh erythroblastosis fetalis and occasionally ABO hemolytic disease. We haven't asked the parents actually of their blood type and the babies. However, there might be a note of possible hemolytic or blood type incompatibility. In this case, more than the breastfeeding or other physiologic form of jaundice, as noted, Kernicterus more so displays or is manifested in patients with such conditions or the hemolytic disease. So risk factors again include, as noted in the patient, exclusive breastfeeding, is age-related jaundice, and total serum bilirubin level above 95th percentile for age. Minor risk factors include the following, with present in our case: male gender, maternal age of greater than 25 years, jaundice observed before discharge. Diagnostics to know if patient has hyperbilirubinemia leading to acute hyperbilirubin encephalopathy and or eventually Kernicterus. We measure the total serum bilirubin, and at birth we plot this total serum bilirubin or the transcutaneous bilirubin on a Botany normogram and determine if it is assessed as high risk or if the patient is above the 95th percentile for hyperbilirubinemia. Hence, after plotting, we determine if there's a needed intervention such as phototherapy, exchange transfusion, or whatnot. Then we also do blood typing to determine if there might be a possible ABO or Rh incompatibility. Coombs test to know if there's an autoimmune hemolytic anemia going on. Liver function test if the liver might be dysfunctional or if there's a diseased condition of the liver. MRI to determine again if there is deposition of the bilirubin, unconjugated bilirubin, in certain parts of the brain, particularly in the basal ganglia, leading now to a diagnosis of Kernicterus.
So I'll be discussing the management. So to prevent acute bilirubin encephalopathy, the management of unconjugated bilirubin focuses on two main elements. The first is the prevention of hyperbilirubinemia by identifying at-risk infants and initiation of preventive therapeutic interventions, such as phototherapy. The second is reduction of total bilirubin in infants with hyperbilirubinemia. This entails enhanced enteral nutrition as a component of general supportive care. And for infants at risk for severe hyperbilirubinemia, phototherapy or exchange transfusion. So the management mainly entails phototherapy and exchange transfusion. Phototherapy is the most commonly used intervention to treat and prevent severe hyperbilirubinemia. This is considered a safe intervention based upon its extensive use in millions of infants, with infrequent reports of toxicity. So these are the guidelines for phototherapy. If above any of the lines here, we would initiate phototherapy. This is the Buchtani normogram, which assesses the risk of an infant to have complications of hyperbilirubinemia. Our patient had a bilirubin level of 42, which is already way above the chart. And the risk of Kernicterus is increased significantly at greater than 35 at 100% risk of developing Kernicterus. So the efficacy of phototherapy, this reduces the total serum or plasma bilirubin concentration, decreases the rise of total bilirubin in almost all cases of hyperbilirubinemia, regardless of the patient's ethnicity or etiology, reduces the likelihood that total bilirubin reaches a level associated with an increased risk of Kernicterus, or at which exchange transfusion is recommended. And we expect a decline of total bilirubin of at least 2 to 3 milligrams a deciliter within 4 to 6 hours. The rate of decline is affected by the following. So an increased irradiance or dose increases the rate of total bilirubin decline. A greater surface area exposure increases the rate of total bilirubin reduction, and a higher initial total bilirubin results in a more rapid rate of decline. The mechanism of phototherapy. So photons emitted by blue to green light in the 460 to 490 nanometer range can photoalter bilirubin molecules that have deposited in the subcutaneous tissues and transform bilirubin into water-soluble, non-neurotoxic molecules, which reduces unconjugated total bilirubin levels. So this includes 3 mechanisms: photooxidation to polar molecules, structural isomerization to lumirubin, and photoisomerization to a less toxic bilirubin isomer. So for the technique of phototherapy, the area covered by the diaper is minimized. The infant is placed in a crib supine, and the eyes are shielded with an opaque blindfold. For total bilirubin levels of greater than or equal to 20, we institute this continuously until total bilirubin falls below 20 milligrams a deciliter. The adverse effects of phototherapy include transient benign erythematous rashes, hyperthermia, interruption of breastfeeding, increased sensible water loss, which can lead to dehydration, and bronze baby syndrome. So exchange transfusion is potentially a life-saving emergency procedure that reduces the level of bilirubin. Although this is rare, expensive, time-consuming, and requires clinical expertise, it is considered the most effective method for removing bilirubin rapidly. So this is indicated for infants who are symptomatic and have signs of acute bilirubin encephalopathy, regardless of the total bilirubin level. This includes significant lethargy, as in our patient, hypotonia, poor sucking, and high-pitched cry, severe hyperbilirubinemia, or total bilirubin of greater than 25 milligrams a deciliter, and rapidly rising TB levels, and failure to respond to phototherapy. So these are the guidelines for exchange transfusions. Any levels above the lines would require exchange transfusion. So in exchange transfusion, the infant's circulating blood volume is about 80 to 90 milliliters a kilogram.